Hi, anyone there?
A very good evening, sir.
Good evening. How are you?
I'm good, sir.
Right. Okay. Can I check my presentation?
Definitely.
Can I do share screen now?
Yes, sir.
Are you able to see?
Yes, sir.
Yes, yes.
Okay, fine. I'll just run through. Is going on well? Yeah. Okay. So I'll just stop share now.
Do you have any videos, sir?
No, I don't have any videos.
Okay, sir.
Okay. How are you, Amit?
I'm very well. How are you?
Yeah, good. I saw you
Very
briefly in Bangalore, but by the time sort of when I came back again, I think you had disappeared.
Bangalore was a hurricane trip because I was caught between two meetings. So in the afternoon, I had to leave. Against my wishes, but I had to leave.
Right. Okay.
Yeah, it was a good conference.
Yeah, it was. It was.
But I see there are so many Uro Oncology conferences. All the topics are now clashing with each other.
Everybody's a urological oncologist nowadays.
Everybody's a urological oncologist and everybody's doing a Uro Onco conference. And if you look at the topics, they're all the same.
Yeah, no. I'm afraid, I think with this, just a second. I'm afraid we might lose that kind of sort of zeal,
Yeah.
If it is a rarity, then people would try and sort of see that. But otherwise, am I audible, Amit? Is it good? Or
Very well, very well. Yeah. No, perfect. This is absolutely perfect. Looking forward to this. These are very modern topics and very relevant. So life is coming back to normal?
Life is coming back to normal, almost normal. In fact, did I tell you we have built a new hospital, which is about 350-bedded new hospital?
Oh, you didn't. Oh, great.
No, it's a multi-speciality hospital we built. And
What do you mean we?
There
You
was
yourself?
a group of, me and about 6 of my friends.
Oh, very good.
So it has come out
That
so
is the
well.
best way forward.
Yeah, and this is the first time the hospital is built by the doctors for the doctors. No admin, no corporates or anything like that. And it has come out very well. 3 months ago we started it.
Is it a charitable hospital? Have you got a charitable bias to it?
No. It's a purely private. I'll show the building. It's completely, what can say is it has a corporate look. 100-bed ICU.
100-bedded ICU.
Yeah.
Good Lord. So because it's multi-specialty, so
It's a multi-specialty.
Where is it?
It's just 2 minutes drive from my home in Sangli.
Sangli. Okay. Okay.
See, I had this Siddhivinayak commitment with me, and at the same time, I was working in my private group. So 3 days I was in Siddhivinayak and 3 days I was in private group. So the private group decided to build a new hospital. So we started in 3 months ago. We already seen 9,000 patients. So,
my God, of course it will be. Doctors' hospitals always pick up fast because the intention is very clear and there is a lot of flexibility as well.
Yeah.
And I think in India is going to move in this direction. I don't know what is going to happen, but I think it's a little bit of a hodgepodge at the moment. I think we are not giving good service. We get excited with certain things which are not actually relevant. First of all, I do not think, though I've learned the robot, not to a very great extent, but I feel that people have gone crazy with the robot.
I know.
And with technology as such. Even in the days of robot, I still feel, I was reading a statistic somewhere. I think not even 2% of cancers in Uro Oncology is being treated with robot in India. However, there are about nearly 100 robots now. So, there is a message in this. There is definitely a message in this.
You see now new entrant in robotic, Santosh Kumar. I can see. Hi, Santosh.
Hi, good evening, sir.
Good
Can you
evening.
hear me?
Yeah, I can hear you. I can hear you.
Okay. Hi, Dr. Amit.
Hello, hello.
Good evening.
Santosh is the new hero now.
No,
He's
no.
bubbling with energy.
Just a minute,
So
sir. Dr.
when did you come
Amlesh
back from?
online.
When did you come back from Kathmandu?
Tuesday I came back. Sir, 1 minute.
Oh, very
Hello.
good.
Okay. Okay. Okay, sir. You busy with something? Okay, sure, sir. I'll take care of that part. Thanks, welcome. Sorry. I think Dr. Amlesh has a problem joining. So I think anyway, I'll take care of that.
Yeah. What was he supposed to do?
So just sharing on comment on adrenal imaging.
Oh, okay.
If you're happy
Good
to
bunch
do
of
that, I'll
topics.
leave that on you. Huh?
No, I'm not. No, you carry on. I think it's a very good bunch of topics. Very good.
Hi.
I think it's a
Thanks, sir.
breath of fresh air because, I was just telling Makran that, there are so many Uro Oncology conferences now. If you collate the data, you will see same topics being repeated in all the conferences.
Yeah.
The same, MRs. PCs.
Hi, Ravi.
Hello.
Good evening, sir.
Hi.
Hello, sir.
Hi, Dr. Ravi. Welcome.
Hi, Dr. Makran. Hi, Dr. Amit. Hi, Dr. Santosh.
Hi.
Hello, everyone.
So, Dr. Amlesh has stepped out
Okay.
at the last moment. So, Ravi, his thing for comment was on adrenal imaging. And the
Okay.
imaging is not functional, just a CT for adrenal evaluation.
Okay.
If you are happy, otherwise I will cover that. I'll be anyway doing the whole thing. So I think if you're okay, we'll give it to you, Ravi.
I'm okay. I'm okay, sir.
Okay, then I just cut it here and I'll put your name.
Sure, sir. Okay.
Dr. Anuradha Chandramohan is the speaker. She's a
Okay.
very experienced uroradiologist specializing in abdominal imaging and worked in the UK plus here. Yeah. Hi, good evening. Dr. Anuradha is also here now.
Good evening, Dr.
Hi.
Santosh, you have a lovely image. You are sitting at the helm of the affairs of CMC Vellore, it looks like.
So I just have this as my this thing backdrop. So
It's
I'm not
wonderful.
sitting and it's not a sunny day here. It just feels as if I'm sitting in front with the hospital view.
Dr. Chandramohan, where did you work in UK?
Sir, I worked in 2 hospitals, Colchester and Basingstoke.
Correct. Good. And when was that?
That was between 2015 and 2018.
Okay, good.
Good evening, Dr. S.K. Singh.
Good evening to all of you
Good evening,
I
sir.
hope
from the Pink City, Jaipur.
you are in Jaipur. Okay.
Sitting in the hotel. I'm trying to arrange for the connection. Yesterday, one of my colleagues, he has bad time because he was on meeting and then there was interruption. So I have my mobile with me and laptop with me. Ravi.
Sir, good evening.
Good evening. Dr. Ravi has now seen me for last 6 days.
Yes, I'm seeing you here, sir.
The exam is here. They have got 10 candidates, 4 days
Okay,
exam.
Oh, wow. So you'll be back on Thursday.
No,
So,
already I have going to conclude tomorrow before noon. So returning back.
So 4 days
tomorrow.
exam just takes off all the practicing urologists from the examination.
No, right.
Only academic urologists can do 4-day exam.
I do that. I agree.
Practicing urologists cannot afford that much out of the practice.
Agree. So I thought, yes. So because the university, they have restrictions. They can't have exam for more than 3 candidates in a day. And national board examination is, again, you can have entertain up to 4 candidates. That's good, Dr. Santosh. You brought me to all of you. Thank you very much.
No,
Yes,
thank you. Actually, in spite of your travel and other things, you have taken time off. I'm sure there's a good party and drinks being arranged there. Hi, Dr. Girdhar.
Yeah, today I've told you, please excuse me.
Hi, sir.
Can I request all the presenters to please open their PowerPoints and just minimize them and keep them on their desktops on the first slide? And so that when
not even minimize, sir. They just keep it on the background, because minimize also sometimes while sharing it creates a little confusion.
Okay.
Just open it in your backdrop so that the moment you start share, you see it.
Good evening, sir. Am I audible?
Yes,
Hi,
very
good evening,
audible.
Sanjay.
Good evening, sir. Thank
Thanks,
you.
Sanjay. Still waiting for Dr. Raghavan and Dr. Naik. So,
Dr. Naik already joined, sir.
I'm here, sir. Good evening. I'm already here.
Hi, good evening, Dr. Naik.
Good evening, sir.
Unfortunately, my screen is showing very few people, and if you don't speak, you don't pop up on the screen. Thanks.
Hi, sir.
Hi, Prishmano, how are you?
Good. Thank you, sir. How are you, sir?
Yeah, good.
So irrespective of how many people are around, I can see already quite a few. So we will be starting on time at 7:15, and hopefully the program is supposed to end by 8:20, and if everybody sticks, we will not exceed 8:30. From the past experience, people very drastically fall out once we exceed the time. And it will be good if all of us could stick to our 10 minutes and our senior faculty to restrict their comments to 2 minutes. If anybody wants, I'm sure there's no videos, but if anybody wants to see if their video is running, please check it out now. It's from your own desktop, so videos will be linked. There shouldn't be a problem.
It's usually a good part in radiology sort of sessions, not many videos like surgical or other clinical meetings.
No, sir. Radiologists actually, they can have quite good
Quite a
videos.
lot.
They may run the cine loops of the imaging. Unlike urologists, we are not good at that, but they can run, and they have more powerful computers also, and better definition computers also than us. So that gives them the killing edge, in reporting compared to us.
That's also easier, people sitting on a computer screen in a workstation, and they just scroll to the CT, you just do a sort of a video of less than 2 minutes. And this is rather than seeing the films is much easier. And all the residents in that.
Sure.
Easier.
Welcome, Dr. Nitin. Good evening.
Good evening.
Hi, Nitin.
Hi, Makran. How are you?
Long time no seen.
Yeah, you are a busy man. I am free now.
I was told that the Nitin is much busier than before.
See, who is sitting in operating dress? I am sitting relaxed. You are still operating.
I'm waiting for my turn to get into theater,
That is the difference, man. We are just relaxed people. So how is everybody? How is your family? Everybody okay?
Yeah, it's good. Yes, good. I believe you are now in a new place.
Yeah, he's in Vellore only.
Yeah, I know, but
Working place is new one. All are alumnus of CMC Vellore only, so I think he's comfortable.
Singh Saab,
Namaskar, Hujur. Namaskar.
Good evening, Kekre, sir.
good evening, Ravi. How are you?
I'm good, sir.
तूने
I
वो
enjoyed
study
your.
वो तेरे
Sorry?
study का क्या
मेरा स्टडी का क्या सर?
वो corroborative research में तो BCG करने वाला था ना ये
हाँ हाँ हाँ
अभी भी वो
ठीक है,
drop out नहीं
अभी अभी करते हैं सर फिर. I thought it's got in a cold box, otherwise तो करते हैं अभी. I enjoyed your lecture on the TRBT on Teachers Day, sir. It was really nice.
Thank you
मजा
It's
आया.
always. I think one introduction also I was very happy to listen from the person who was introducing him. Dr. Nitin means the person who is the mind of principle.
Principal Niti. Yeah.
So yes, I think Niti. So now see the thing, many things may not be noticed by us. And now the youngster can find out they can derive some meaning of that. He's true to his name that he was talking, and then I'm remembering this. Maybe thus I'm trying to tell Dr. Nitin that I was there throughout. And I released his lecture as usual.
नहीं सर लोग सब रोबोटिक की बात कर रहे हैं हम तो पुराना ऑपरेशन टीआरबीटी
आपने ठीक ही बोला सर. यस, कोई बात नहीं करता टीआरबीटी. दिस इज द मोस्ट कॉमनली परफॉर्म्ड प्रोसीजर बाय urologist. And so many minute point you told, even I was learning many things. Yeah, I do learn many times, but there also I learned something, many good things. And I have been narrating that statement, your statement, to my colleagues and to my residents, because you are a teacher. And that's why I thought as a teacher, I should convey the message from a teacher. Because many of them, they have not joined continuously. Very nice teachers day, sir. That
Good evening, sir.
Hi, Dr. Sir. Dr.
Hota, sir. Good evening.
How was the andrology meeting? Dr. Hota?
It's always high flying andrology.
all good directions.
Absolutely correct. Huh?
We used to call them organ riser.
Okay, we have 5 more minutes. I think most speakers are there, and I'm just contacting some of them whom I can't see. I presume they're there, but I may not be seeing them. Let me check the whole crowd. Yeah.
Sudhir Rawal isn't there.
Yeah, Dr. Jagdish, Dr. Sudhir Rawal, Dr. Sabnis, Dr. Keshav Murthy. We have to start with Dr. Sabnis.
में क्या करा दिया आज?
Much time, 5 minutes more.
Yes, sir. Very good evening there. So,
Good evening.
Welcome, sir.
Thank you.
So, Nitin, how are you?
हाँ ठीक है.
Hi, Ravindra.
Hi, Makaran. Busy as usual.
Not busy.
Makaran.
Bolo.
Only tea in the cup or is Baba Saheb Thackeray trick?
Is 7 o'clock. So maybe by 8:30, I think it should be changing, you know.
So meeting for 15th is over. Plus I was finding it difficult.
Yeah, that is good.
Good evening, Ji.
That is good. Everybody was hoping for that.
Yeah,
Only I have
cover.
Nitin is fully satisfied.
Yeah. Anyway, I already told them not coming.
Yeah, I wrote. I saw that.
Everybody has their own personal problem. Certainly, we have to come to amicable solutions. We is that Dr. Ajay Kumar should recover quickly. So I have a dengue with me. Again, I suffered from dengue and I remained moribund for 1 month.
Is it?
Very lethargic. Yes, yes, very lethargic. Rather, I was Dr. Ravi remembers that I was I was doing a robotic surgery alone. Then when I got up, then I started swinging. The sister caught hold of me, then say, "Aapko to bukhar hai." So immediately the BP was checked, it was 90/60. So really, so they were worried. They were worried. Then I told them, I was sorry, Dr. Ravi, please come over to OT and take over that robotic surgery. So that time, 3-4 years ago.
I had a very severe typhoid and I was weak for almost 3 weeks.
So now we are.
These are all major problems. We don't realize.
Yeah, so that's something, when we suffer, then we do realize how the people might be suffering, and then.
So I have to remind everybody we are not getting younger every day either.
That is the main thing.
We try and feel that sort of we can do, but I think that also is a warning signal. We feel we can, but we can't.
Correct,
Yeah,
correct.
Navneet, can somebody give us a countdown 30 seconds before and give us a so that we can start on time?
Sure, sir. We have around 2 minutes to start.
Yeah, and Dr. Sabnis will start, then I'll take over, and then the first speaker will be Dr. Makaran. And please, I hope you have the program so you can put everyone one by one for the screen sharing. Yeah.
Right.
So, sir, my humble request, all presenters, please stick to 10 minutes and the comments be restricted to 2 minutes. And we need to finish at any cost before 1.5 hours because we don't want attrition to happen. We want people to stick around till the end.
Correct, correct. Absolutely true. After certain time, the public concentration becomes almost negligible.
No, Teachers' Day, it was so perfect. Perfect lecture, precise lecture, and finished on time.
So we already have 43 participants in the thing. So I don't know if it's being relayed on YouTube also, if we can know what is the number there.
Yeah, 44, sir.
Okay.
We have trickling people coming in, sir. Around 5 to 7 people are watching on YouTube, sir.
Okay. So Dr. Sabnis will be starting with you.
Yes, yes.
And
I'm ready.
Sir,
And
we
gives time, I will start.
Sir, we can start, sir, with 7:15.
Welcome all of you for this first of this webinar organized by the Uro Oncology section of USI. As you know, the sections are now have become very active. They are doing this program in a very nice way. And if you go through the program, it is a compact program involving almost who's who of Uro Oncology in India. And the program is so attractive that anybody who reads, I'm sure will be tempted to attend the whole program. I must give credit to all the conveners and especially to Dr. Santosh Kumar for this particular program, for chalking out, taking the lead and making sure that the program is made in such a way that it is useful, not only to the those who are practicing specialized Uro Oncology, but also to the general members of USI. So I must congratulate them and welcome all of you for this Uro Oncology webinar. Over to you, Dr. Santosh Kumar. Please take over and continue with the program. Thank you very much.
thank you very much, Dr. Sabnis. A very good evening to everybody. Thank you, the conveners, the speakers, and our chairman who will be passing on comments. So, as you know, imaging is a very important aspect of any surgeon's life, and more so for a Uro oncologist. And actually, this is the third of the trilogy that the conveners were supposed to do. And initially we had planned that we'll take organs one by one. And we started with bladder, but very soon we realized that we should do something more specific and interest. And then we did one on Omnics, which was done by Dr. Gagan Prakash. And then Dr. Amit Ghosh actually suggested, why don't I take up imaging? And I actually like the idea because imaging was very close to my heart and something that I always find challenging and interesting to debate on with our radiology friends. So imaging in oncology could go on from screening to diagnosis to staging to planning treatment to then executing the treatment and then follow up. And in each of these steps, you may have to choose a precise imaging modality and interpret it correctly to get the optimal results. A small change, a lymph node positive somewhere, a bone metastasis positive somewhere, where a radiologist could help probably telling that this is a bone island, probably this is a benign lesion, don't need to worry, or where they could confidently say, no, this node looks malignant because of these features, or this bone lesion looks malignant. And add to that today a functional imaging where very, very small lesions also could be detected in a very early stage. And we get so bombarded with so much of information. Sometimes the tests are very easy to order, but we don't know what to do with them when we get that much precise information. So this webinar has been planned to cover up imaging, and I have the who's who of Uro Oncology, the young budding stars, all the champions of the present era who will help us guide through this. And without wasting any more time, I would start with Dr. Makaran, and he'll be speaking on the role of PET CT in two specific scenarios. One is in seminoma and the other is in inguinal node metastasis and carcinoma penile. So over to you, Dr. Makaran.
Good evening, everybody. Am I seen there on the screen?
Sure, sir. You can put a full screen and we'll look.
Yeah, thank you very much, Dr. Santosh. It was very kind of you to sort of, invite me for this session. Dr. Sabnis, Dr. Keshav Murthy, my good friends, Dr. Nitin Kekre, Dr. Jagdish Kulkarni, Dr. Singh, Ravi Mohan, and everyone. The task which is given to me is about the role of PET CT in seminoma and penile cancer. Greetings from my hospital, Siddhivanaya Cancer Hospital, where I've been working for the last 25 years. And this is something new what we started just about 3 months ago, a new 350-bedded multi-specialty hospital, where we established another department of urology and urological oncology. So let us start with testes, the germ cell testes, the germ cell tumor of the testes. When we use sort of, sorry?
No, go ahead.
Right. Now,
Only
basically,
can you make a full screen, Makaran?
Yeah, I have made a full screen.
No, but it is still not. I think you stop sharing and sharing again because it is not coming full screen.
Okay. What I'll do is I'll stop share. Okay.
Again.
Share again. Are you able to see now?
No,
We can't see the full screen.
But I think it is okay.
Yeah, I think just carry on, sir. Yeah.
We can see very well. There is no problem.
Okay, fine. So basically the tools what we're using currently for the staging and metastatic workup and follow-up, currently we have two tools. One is a CT chest and abdomen, and tumor markers are so vital in testicular cancer. Now let us look at all these imagings and what tools we have, and is there a role sort of a PET CT in given circumstances. Now we use CT chest and CT abdomen as standard of care. Still the problem lies with this imaging. When we have a mass of 3 centimeter or less, then does it have a metastasis, inside? Many times we have an inaccessible mediastinal lesions, not good for a biopsy. Can we have a tool which can tell you whether there is a metastasis or not? Tumor markers, absolutely wonderful. But what happens in seminoma, only less than 10% of seminomas will have elevated beta HCG. And when you have lesions in the retroperitoneum, mediastinum, beta HCG is normal. You don't know whether patients have metastasis.
I think your slides are not moving, sir.
Slides are not moving?
Yeah.
Are they? Are they
No,
moving
we
now?
cannot. No.
Actually, maybe that you have done before you.
Yeah, we have checked it.
You started sharing. maybe you have to stop sharing and then load the things again. This happened with me once. I was talking in extempore and then slide was moving. I thought it's moving with me only. It was not moving to the audience.
Okay.
So maybe now once you open and minimize it, then you do it again.
Okay, because we checked it before we started. I'm sorry about this.
No, this may be that you can see, but others may not be able to see the movement. The main point is theirs being shared, the title page.
You have opened PowerPoint on the background, no?
Yeah, I have. Are you able to see this now?
Now. But it's again, yeah, we are seeing only the slide which you are talking about.
In the slide and see. In the slide and see.
Yeah.
Yeah, slides are changing.
Slides are changing.
Yeah,
so
now it is.
If I keep it like this, is it okay?
Is it okay? It is okay. If the slides
fine.
slides are changing, so it is okay.
Okay, fine. So basically, the point I was driving, sorry about this. The markers, only less than 10% patients with seminoma will have elevated beta HCG. And when you have lesions in the retroperitoneal mediastinum, you don't know whether it is a metastasis or not on a standard imaging. Now, talking about primary RPLND is almost going out of the fashion. And many times you can have failure outside the template also. For we're talking about stage 1, sort of a non-seminoma germ cell tumor, not for seminoma as such. And what about post-chemo RPLND? Yes, that is a norm, it's curative, guide for the further course of action. But in metastatic seminoma, it's extremely challenging in this kind of situation. Now, given that background, can PET-CT bail us out addressing these issues and challenges? And the task which is given to me is about metastatic seminoma post-chemotherapy. PET-CT in general has better sensitivity in seminoma than non-seminoma germ cell tumors, maybe the mixed histology, teratoma, poor uptake, and that's why seminoma has more sensitivity with a PET scan. Now, in terms of metastatic seminoma management, stage 2A, B, C, these are the lymph nodes in the retroperitoneum. Stage 3 is sort of metastatic disease. For stage 2A, we give radiation to retroperitoneum after orchiectomy. For stage 2B, C, and stage 3, we give chemotherapy. If post-chemo, the markers are normal, post-chemo RPLND is advised for residual masses for more than 3 centimeters, but there is always a challenging situation as compared to non-seminoma germ cell tumor because there is a lot of desmoplastic reaction in these kind of patients. Just to show you, this is a case of stage 2B non-seminoma germ cell tumor treated with hyoarchidectomy with 4 cycles of chemotherapy. Post-chemotherapy, the markers have come back to normal, and you can see sort of a large mass in the retroperitoneum. You can do an excellent job. You can skeletonize the whole aorta and vena cava. You can see the inframesenteric artery. And that's not a big deal in experienced hands and experienced centers for a non-seminoma germ cell tumor. Similarly, large tumors like this, large teratomas, even though they are challenging, the vessels are all stretched out. You can do these kind of surgeries in non-seminoma germ cell tumors, and you can achieve a good clearance in the retroperitoneum, big masses. Come to seminoma. This is a case of stage 2B, a large mass just behind the vena cava. Patient had hyoarchidectomy. Subsequently, this is sort of a retroperitoneal mass at presentation after orchiectomy. 4 cycles of chemo because it's a bulky seminoma. Shows good response, but still big element of lesion just behind the vena cava. So when we do this surgery, you can see the difference. The slides I showed you before, you can really skeletonize beautifully out and vena cava, but in seminoma, there is fair amount of desmoplastic reaction, and you really struggle going into this kind of area, though you may not be able to, maybe you may not be able to achieve R0. So coming to the point, what is the role of PET-CT in metastatic seminoma? This is a wonderful article which has come in Frontiers in Oncology, and what they suggest based on ESMO guidelines, European Society of Medical Oncology, PET-CT generally not recommended as a standard diagnostic modality for a primary staging. So still CT chest and abdomen is a standard of care. ESMO clinical guidelines also suggest that post-chemotherapy setting is to assess the residual disease in patients with seminoma is still debated. And let me explain. What happens in metastatic seminoma? We know the viable cancer cells can be found in 12 to 30% of the patients after the first line of chemotherapy in advanced stage of seminoma with residual retroperitoneal masses which are larger than 3 centimeter. If the mass is less than 3 centimeter, it's still about 10% patients can have viable cancer. And there is always a desmoplastic reaction. And that's why it is very challenging situation. If you have negative PET CT performed around 6 weeks after the last chemotherapy, then perhaps you may think that patient may not have a disease inside. But if you have a disease which is more than 3 centimeters, then patients may have sort of a viable cells in that. There have been a lot of studies, even the positive scan may be because of granulomatous inflammatory changes, necrosis, and that's why it would have an inconsistent results as such. There was a SEMPET trial in 2011, about 125 patients. Patients had undergone post-chemo. These are patients with seminoma stage 2 BC. And you see your sensitivity as well as sort of specificity, and look at the positive predictive value. Very, very low positive predictive value, but it had a high negative predictive value. This is a study in 2014. It was a meta-analysis of 9 studies that included 375 scans of heterogeneous group, and they divided these patients with a less than 3 centimeter mass and a more than 3 centimeter mass. Positive predictive value of 58% and negative predictive value of 94%. And they found that if the mass is bigger than 3 centimeter as compared to less than 3 centimeter, then maybe it is useful, but not otherwise. This was another study in 2018, about 90 patients by Kathamas. And this was one study which showed very, very low positive predictive value. So you can see sort of variable results. The European consensus among the experts in management of GCT have concluded that if the mass is less than 3 centimeter, then the performance of PET CT scanning is insufficient. But if you have more than 3 centimeter, high negative predictive value of 94-96% can be something interesting. So there is a strong argument for observation in these kind of cases. But the positive predictive value of 23 to 50% for the masses of more than 3 centimeter may provide an argument for post-chemo RPLND. Maybe you have to consider to do it in tertiary care centers and patients who are doing quite regularly. If you have an equivocal result, maybe you can do a follow-up PET scan within 3 months and take a call thereafter. And if you don't feel comfortable in doing the surgery, maybe patients could have salvage chemotherapy initiation upon the unequivocal findings. Now, these are certain examples. We see the PET CT after sort of, patients treated with chemotherapy. There is not much uptake seen in this picture, but this seminoma has a fair amount of uptake. Now, take this patient, stage 2B post-chemo. CT showed and PET CT also 6 weeks post-chemo. This is the residual mass here. Not much activity, but don't rely on that. Repeat the scan. After 3 months, you see there's a positive uptake. The patient had to have a surgery and excision of the residual mass and RPLNT. There is another interesting article on sort of use of FDG PET in testicular cancer, and this was highlighting the EUA guidelines. And the EUA guidelines suggest that the residual mass of more than 3 centimeter after chemotherapy, I think there will be a place for PET CT. That's what they say. The use of PET CT led to significant reduction in the over-treatment from 72% to 30%. And the under-treatment was decreased from 14% to 7%. And this was something highlighted. So even EUA guidelines suggesting that it may have a role in patients who have mass which is more than 3 centimeter. In less than 3 centimeter, the authors also concluded there could be sort of a case where we could avoid unnecessary adjuvant therapy after chemotherapy because it has a very good negative predictive value. So in conclusion, FDG PET CT can have a role in post-chemotherapy residual masses in seminoma. Residual mass of 3 centimeter need to be carefully observed for active disease. Relapse with CT and MRI, that should be standard of care. If the mass is more than 3 centimeter, if it is PET negative, can be observed. If it is PET positive, should undergo post-chemo RPLND in expert hands and salvage therapy. In equivocal results, it is better to repeat PET CT after 3 months. Now, the second part of my talk is about penile cancer. And basically the thrust is on inguinal lymph nodes. So like I said in testicular cancer, what are the current tools for staging and metastatic workup in carcinoma penis? Obviously, we rely on clinical findings. We rely on CT scan, abdomen, pelvis, and chest. We do FNSC when we find lymph nodes. There is also a role for dynamic sentinel lymph node biopsy. But having done this for years and years, they do have sort of pitfalls. They have limitations. And do they really make us a wiser? So let us look at these tools. Clinical examination, extremely important. You go by sort of what you think. And also there is a risk stratification model. But, it's not reliable in obese patients. CT scan shows lymph node of less than 1 centimeter, 1 to 2 centimeter size. Do what? FNSC, you may not be able to do sort of a proper sort of an FNSC in patients where lymph node sort of in the pelvis itself, and dynamic sentinel lymph node, it can be invasive. Now, can PET CT bail us out in a situation where we still rely on sort of risk stratification, depth of invasion, and then sort of take it, whether we should do prophylactic lymph node dissection or observe in patients, especially on N0 groin. Now, there are studies of a PET CT in N0 groin. One study in 2005 showed 13 patients, specificity of 100%, sensitivity of 89%. There was a study in 2019 about 21 patients, good specificity, but very, very low sensitivity, and it was limited by sort of findings that it has low sensitivity in micrometastasis. Another study in 2012, 88% specificity and 75% sensitivity. And there was a meta-analysis in 2012 about 7 studies, and it shows sensitivity of 57% and a very low positive predictive value of 25 to 37%. So we don't have become much wiser with the PET scan. There was a good article from Netherlands in 2017, and what they said, the exact role of PET CT is still ambiguous. The pelvic metastasis and occult distant metastasis may be something you can pick up, and then you can decide whether you want to give upfront chemotherapy to these patients, and also tell the patients what's the prognosis like. However, the evaluation for the indication of a PET CT in larger cohorts is really warranted. I'll show you a few sort of examples, and then I'm going to close. When you have a classical lesion which is seen, palpable, and demonstrable with a biopsy, this is a lesion which is seen in the carcinoma penis. I don't think PET CT adds to any information than what you would get on clinical examination and standard CT or MRI. In fact, I would say the exact local staging is better with MRI if you want to see sort of an infiltration of urethra, carpura, and even if you want to see the infiltration of the vessels, the great vessels, the femoral vessels for the lymph nodes, because on PET CT, there is usually a diffuse uptake in the primary lesion. Also, the FTG is seen in the subprofusal area as well as in the urethra, so that also makes life a little bit difficult. Now, this patient has clinically significant lymph nodes into the inguinal region. You also see sort of positive uptake in the pelvic lymph nodes. Maybe you can consider whether you want to give neoadjuvant chemotherapy in these kind of patients. Mind you, when you see the reports like this, a lesion like this in the vertebra or on the mediastinum, now usually at presentations, in a patient has a T2 disease, moderately differentiated, unlikely to have bone metastasis. I'm not sure not. When the patient was subsequently investigated, was found to have a sarcoidosis. So maybe you can take this sort of images with pinch of salt. A local recurrence after partial penectomy, ideally you should not get much if you do a good R0 job and lymph nodes are also very well cleared, but that is also picked up on a PET CT. It was a very good article for the trainees. I think you should get through this paper in Cancers 2022. It's a wonderful article, covers all about PET CT and imaging in genitourinary cancers. See, this is a lesion in the subprofusal region. You can see that, and this is sort of positive uptake in the right inguinal region, but you don't really need a PET CT for these kind of information. Also, similarly, you see a lesion like this, diffusely seen on a PET CT, a fungating lymph node, which is obviously going to be positive on a PET CT. So it doesn't add any information. What all I want to know, whether there is sort of an infiltration of the femoral vessels and adjoint structures. This is something metastasis to the penis from sinonasal undifferentiated carcinoma. This is something what you can pick up on a PET CT. So basically, in terms of sort of a squamous cell carcinoma, one added information or one added benefit what you can get is there was a paper which suggested that if you have a high concentration of excreted radiostressor in the bladder and external contamination, this will give a lot of problems. Inflammation can also give a problem. NCCN guidelines also suggest that it's a routine use is not really necessary. But one more use, maybe if you have a maximum standardized uptake values for a primary lesion and lymph node metastasis, and cancer aggressiveness and cancer-free survival can be studied. And this was only one paper which came in this kind of study itself. So in conclusion, PET-CT in penile cancer, though primary lesion is FDG a bit, there is a diffuse uptake, therefore exact extent is not well delineated. MRI-CT is much better. FDG in the urine and urethra can be bothersome in interpretation. Not very reliable tool in In Uro groin, which is challenging situation in management of CA penis. If you have positive in one lymph nodes, uptake in pelvic lymph nodes and distant metastasis can be picked up in majority of the cases, may be useful in planning NSAT in those if need be, and therefore its routine use in carcinoma penis is not recommended. NCCN, ASCO, ESMO all say the same. Thank you very much. I'm sorry that we had to spend some time because your slides were not very well set.
Thank you, sir. I can unshare. And Dr. Nitin, can you please give your comments?
Yeah, thank you very much, Santosh, for inviting me to participate. I think Dr. Makarand has covered the topic. The most important thing about the role of PET-CT in seminoma is only in the context of a residual masses. Nobody uses PET-CT for a primary staging. What is the difficulty? As was alluded already, that the difficulty is you can't easily excise seminoma post-chemo as you could probably do with non-seminomatous tumors. Most important thing to remember, and the point which was mentioned, but I think not emphasized enough, is that the most important thing is not to do the PET-CT in these residual masses, at least for 6 to 8 weeks. Important to reduce the false positivity rate. The most important thing, PET-CT, yes, negative predictive value is high, very high importance, but false positivity is not very bad. It's not perfect, but it is about 11 to 38% depending on which study you take. So it still acts as a guide, especially in cases like this. And most of the people believe that when there is no volume increase and there is a borderline PET avid activity, that one can easily wait and watch and repeat. And that is mostly possible because one must remember that the positive rate or a positive relapse rate in residual masses is very low. It's about 14 to 20%. So that is in that context, we must look at these masses. And the PET-CT does help you there. And salvage chemo or salvage radiotherapy can be a rather safer option unless you work in places like Indiana where they can take everything out, even in the cases of seminoma. So in the literature, most of the post-seminoma residual masses excisions are from Indiana, where they maintain that that is much better treatment than salvage chemo or radiotherapy in these situations. So I think that is most important, that the PET scan has added tremendously in a management of post-residual seminomas, because the negative predictive value prevents you from doing these unnecessary morbid operations or giving them morbid chemo or salvage radiation. So that is the most important thing. About CA penis, I think Makarand has very clearly alluded to that, frankly speaking, there is no role. Most of the slides which he showed later, nobody uses PET scan. I mean, it's not necessary. What are we looking for? We are looking for negative groin. Can PET-CT tell me there is a MET in negative groin? And the answer is equivocally no. It does not do any better. So obviously, PET-CT hasn't added anything in the management of carcinoma penis. We still remain, if you have a facility of DSNB, you will do them. Otherwise, people like us will perform probably a modified inguinal lymphadenectomy in a negative groin in patients who have a primary biopsy, which shows the risk factors where the possibility of micrometastasis are high. So when you have a high risk penile cancer, negative groin, even today, I think modified inguinal lymphadenectomy is an answer. Thank you very much.
Well, thank you, Dr. Nitin and Dr. Makarand. And now I call on Dr. Sanjay Sureka, who's the additional professor at SGPGI, and you can start sharing. His role is to look at, has PSMA PET actually made a difference in the management of carcinoma prostate? It's a new investigative modality. Everybody has been using it. Is very sensitive. It can pick up very small things. But the question is, has it made a difference in the management? Okay, over to you, Sanjay.
Am I audible, sir?
Yes, yes, please.
My slides are clearly visible?
Yes, yes, yes. Full
Yes.
screen. Carry on.
So I would like to thank the convener as well as the president USI for giving me this opportunity. So today my task is to discuss regarding the role of PSMA PET scan in management of prostate cancer. So I don't know why the slides are not moving. So
Yes, it's moving.
I'll say a few words about PSMA, and followed by I'll talk regarding how a role of PSMA PET scan in diagnosis, more importantly, management in cases of primary case, in following biochemical recurrence, and for planning of radiotherapy. And I will also say a few words regarding the response evaluation following a PSMA-based therapy. So PSMA is basically a transmembrane glycoprotein, which we can see on the right upper image. So it has three parts. One is the intercytoplasmic part, which is a 17 amino acid 17 amino acid residue, and the cell membrane part, which is 24 amino acid domain, and the extracellular region is 707 amino acid domain. And mostly those radioisotope tagged like 68 gallium PSMA PET scan, they usually bind on the extracellular region, and they being picked up by gamma camera to detect the prostate cancer cell, because this transmembrane glycoprotein overexpressed in prostate cancer cell. It's very important to understand that when we considered the SUV max for a positive PSMA PET scan, that is more than 5, because as compared to FDG in other places where more than 2.5 considered to be significant. The reference for this they always take as liver uptake. The uptake in the liver in SUV max, the reference value is around 4 to 4.5. So more than 5 they consider to be positive. So next I will look into the role in primary cancer. This article was published from All India Institute of Medical Sciences, and they found that PSMA PET scan can pick up 3 times more non-regional lymph nodes and 1.5 times more regional lymph node as compared to conventional imaging. So in high risk prostate cancer. And this article was published in Journal of Urology from Germany group, and they found that PSMA PET scan has a better sensitivity, specificity, and accuracy as compared to morphological imaging. And the sensitivity of PSMA PET scan for detect the lymph nodal metastasis in 65% vis-a-vis 43% in morphological imaging. The specificity was very high, 98% versus 85%. And the accuracy was in this article they reported of 85% in conventional morphological imaging as compared to 72% in PSMA PET scan. This is the best level of evidence we have right now, and this study was published in Lancet in 2020, and a prospective randomized multicenter study from Australia. And they included 300 odd patients in 2 arms. In first arm, in A, they have randomized into 150 patient to CT scan or plus bone scan conventional imaging, and other arm gallium PSMA PET scan. The first line imaging, after 2 weeks, they have crossover. That means the patient who had conventional imaging, they had gallium PSMA PET scan, and who had gallium PSMA PET scan, and they subsequently have CT and bone scan. And they found that PSMA PET CT has 27% greater accuracy than conventional imaging for picking the lymph nodal metastasis. If we see this diagram, we can see the area under curve, which much better in PSMA PET scan vis-a-vis the conventional imaging, and the specificity and sensitivity all are much better as compared to conventional imaging. There is good evidence in the literature that the PSMA PET scan is better in terms of sensitivity and specificity as compared to conventional imaging, especially in high risk category of prostate cancer. Now I will try to find out whether this knowledge will improve the outcome or not. The same study which I have quoted, that Australian study, they have also secondary outcome they measured in terms of change in management in following the first line and subsequently second line investigation, and they found the PSMA PET scan changes the management, high impact or medium impact management in cases of 28% patient. That means if the patient was planned for a radical surgery or some form of radical therapy, they had a different form of therapy in 28% patient as compared to 15% in conventional imaging. Very importantly, they also find out the equivocal results which detected by conventional imaging 23% and 15% of those patients got confirmed findings by PSMA PET scan. It's a very important findings. And definitely the exposure of radiation is also much lesser in PSMA PET scan. So just I'm giving an example of a case of our center. If you see the conventional imaging, we cannot detect any lymph node here. But on PSMA PET scan, there was a pararectal lymph node in this patient. And so definitely these findings will improve the management, even if you are planning for definitive surgery or whatever modality. Now I'll come to the role of PSMA PET scan in BCR. The PSMA PET scan can detect much better percentage wise as conventional imaging, especially when the PSA is low. That is, in PSA less than 2, the detection of conventional imaging 15 to 18%, where it is 40 to 90% by PSMA PET scan. And definitely this will have a subsequent impact on management. This is a systemic review and meta-analysis which was published in European Urology in 2016, and they found that yield of PSA PET scan for BCR is more than 75% when the PSA is more than 1, and it was more than 90% when the PSA was more than 2. And this is again an Australian prospective multicenter study, and they try to evaluate the whether impact of PSA PET scan on management intent in prostate cancer, and they found the following BCR, the PSMA PET scan changed the management intent by 62%. That's 2/3 of the patients. It's a huge number. And half of the patients have management changes in primary prostate cancer. In these all patients, they have included our high-risk prostate cancer patient. Though the level of evidence are poor, but we can find some evidences regarding the salvage radiotherapy protocol following PSMA PET scan, and they found that salvage radiotherapy protocol and planning changes more than 40% patient after PSMA PET scan. So we can see they have given an example like in this right side of the image, you can see the lymph node lit up, and that has been included in EBRT, though it was picked up in conventional imaging as well, but probably they are more comfortable and they've more accurately they can project into the EVRT following this PSMA PET scan. So in therapeutics, the lutetium PSMA has a definitely proved role now in metastatic CRPC, and this is the basis of this lutetium PSMA therapy is always PSMA based PET CT scan. So just an example, we can see the gallium PSMA PET scan picked up a lot, multiple skeleton mates, and after 4 cycle of lutetium PSMA therapy, the mates disappeared. So it's really helpful to evaluate the response of PSMA therapy. So all those PSMA based therapy is based on basically PSMA PET scan. So definitely it has an impact on management. If you see the guidelines, the PSMA PET CT is more accurate for staging than CT and bone scan. More so for high-risk disease, but to date, no outcome data exists to inform subsequent management. So the whether it will improve the management, that is not yet firmly established. So it is not yet in the guidelines, but I think it will come in the guidelines subsequently. And this EU guidelines also suggested to perform PSMA PET scan or PET CT in patient fit for curative salvage therapy following recurrence. The future, I'll say just a few words on the future direction. The main problem with gallium PSMA PET scan is the shelf life. It has a very poor shelf life, low shelf life, so it's very difficult to transport. But 18F PSMA PET scan having a very good shelf life, and this study found that 18F PSMA is not inferior as compared to gallium PSMA for detecting prostate cancer. So it is possible that in future this gallium PSMA will be replaced by some other radioisotope PSMA PET scan. So to conclude with, it definitely increases the diagnostic accuracy, especially in high-risk prostate cancer, very strong evidence, and likely to play a role in management for localized high-risk prostate cancer as well as locally advanced and oligometastatic prostate cancer. It has definitely a role in radiotherapy planning whenever either in primary setting as well as in a biochemical recurrence setting. And better management, it helps in better management strategy or protocol in biochemical recurrence and response evaluation following PSMA based therapy. Thank you, sir.
Thank you, Dr. Sanjoy. Can I call on Dr. Sudhir for his comments? I'm sure he's doing a lot of PSMA PETs.
Yes, Sanjay. Thank you, Santosh, for inviting me for this comment. We are using it for a long time, and we have found it useful in, as Sanjay has already said, that in high-risk prostate cancer, in metastatic prostate cancer, when you can do one-stop shop, you need not to do multiple CT scan, bone scan, or anything, and then biochemical recurrence. There is another role which actually has evolved, not yet in guideline, but we have seen the unusual sites of recurrence, like in testis, isolated site of recurrence, and especially and testis or mediastinal node, and there is another subtype or sub-staging or maybe a subgroup of patients is coming that minimal recurrent disease in CRPC stage, which either can be removed or can be later on radiotherapy can be given. So this does have role in high-risk prostate cancer. In when the patient is organ confined, you can tailor your surgery, you can extend your surgery depending on this thing and can change some time, and also radiotherapy can be planned in a better way. And then in BCR, definitely we always use CT PET scan depending on the PSA doubling time. It's not that in every case we will use PSMA PET scan, and the PSA, if it is less than 0.5, generally we do not use PSMA PET scan. It's not recommended because less than 0.5 PSMA in BCR stage, there are very less chances of getting any evidence of disease in the body. But if the PSA, as Sanjay said, the PSA is 1 or 2, then the chances they increase. And this does change the treatment in biochemical recurrence and also hormone-sensitive metastatic prostate cancer, where you can do a baseline PSMA PET scan, and later on you can compare when the patient is failing or patient is having long-term remission. Also, after that you can also do PSMA PET scan. If it is negative, you probably can stop the hormone therapy also. So there are multiple use, and it is evolving further. It's not staying there only, it's evolving, and hopefully it will be in the guideline everywhere. Mainly the reports are from Australia and Germany. The situation is Canada and America is not very encouraging, as they have not, it's not probably reimbursed or something is there. So they have a very long waiting list of doing PSMA PET scan. But in India, it is quite cheap. In Delhi, even you can do it at 8,000. So many of my patients, they get PSMA PET scan done outside, even for intermediate and low risk group where it is not required. Thank you.
Okay, thank you, Dr. Sudhir and Dr. Sanjoy. And then now I call in our very focused topic on imaging on follow-up of after ablation for small renal masses, and to present it will be Dr. Raghavan from Chennai. Over to you.
All. Good evening, all. I hope you can see me and hear me.
Yes, please go on. Yeah.
Thank you so much. My voice is not in the best of the shape. I'm so sorry for that. And thank you so much, Santosh, for giving such a very specific topic. When you gave it for the first time, I was thinking, what the hell am I going to speak here? But thanks to your guidance, we managed to create a PowerPoint on that. So I'm going to skip 1 or 2 slides quickly. The topic is focused on imaging after ablative therapy. So the ablative therapy that are available are cryo, radiofrequency, stereotactic radiation, microwave ablation, high frequency intense focused ablation, of which cryo and radiofrequency are the most commonly used therapies. I provide these things for the sake of the benefit of the students, but I'm going to skip this and I'll share it in the groups for everybody's better use. Now, once ablation is done, how to follow it up, how to know whether there is a recurrence or not. First and foremost, there are no formal guidelines in this at all. Generally, CT and MRI are used initially for 3 months, 6 months, and then annually for 5 years, 10 years. There is no data to support what is being done. Ultrasound should not be used unless there is contrast enhanced ultrasound available. The imaging protocol that is usually available and routinely used is a CT. MRI is reserved for patients when there is an allergy to contrast or multiple lesions are there and multiple scans need to be done and so on and so forth. Now, how to determine whether there is a success of the treatment? It is usually determined by the fact that there is an absence of enhancement at the treatment site. But we also know that microscopic residual disease may not be available and seen on the CT and MRI and may take months together to pick it up in the thing. And usually also keep in mind, the standard practice is to give at least a 5 to 10 mm margin around the tumor so that the residual microscopic tumor at the margin is taken down. The recurrent disease may it is more likely to represent a growth of an occult foci of a residual disease. So as I said, the CT may not pick up something, but there will be some tumor cells which may in turn grow in size and which in turn is seen as a residual disease in future. The normal spectrum of post-ablation finding. What are the things that I can find after an ablation? Immediately after the ablation, there will be perinephric stranding and may show thickening of the pararenal fascia. The perinephric or subcapsular hematoma may also be seen. Ipsilateral perinephric stranding can also be seen up to 1 month after ablation, which can be seen as a mistaken for perinephric stranding related to infection. So don't panic and start putting stents and antibiotics. CT is classically described as a bullseye or a halo. What happens is there is central necrosis and a peripheral rim. The peripheral limb is more to do with the inflammatory reaction of the surrounding fat rather than a tumor capsule itself. And as the time goes by, there is a normal involution of that halo down as well, because the tumor has shrunk in size. The whole thing has shrunk down in size. And the resolution of the ablation zone will come down. So just these pictures tell you, just pointing out, I do not know whether you can see my arrow or not. You can see the central halo with the rim. Yeah, with the rim. So that is something I wanted to show. And as the time goes by, there is involution, as you can see as well. Now, in MRI, what will you find? That is a CT finding. In MRI, what will you find? The T1 weighted imaging is very important because keep in mind, there will be heterogeneous and often a hyper intense reaction will be there that is related to bleeding. And bleeding is best seen in the T1 images. Versus in T2, it will be hypo enhancement because there is tumor loss there. So you have to keep in mind that it will be different compared to a pre-treatment CT or MRI scan. So that is something you need to understand. There is a CT halo, and this is the halo in the MRI scan. You will see the halo here as well, but it is a different halo that you will see. There is also this benign granulomatous response, which I took help of my friend Satish to understand this, even though I couldn't understand a single word of what they said, but that is what is supposed to be seen. But the lower picture is very clear. You can see the distinct tumor involution. Initially, there is central necrosis and the halo, and as the time goes by, there is tumor involution. So how is a recurrence found? The recurrence is found because there is an enlarging ablation zone. So what happened is the ablation zone, which has become small, will start to become bigger again because the tumor recurrence happens in the peripheries, and there will be new nodular enhancement as well. And if you do a CT, there will be 10 to 20 Hounsfield unit increase in compared to the pre and post contrast increase in the ablative zone. As I said, new nodular enhancement is also suggestive of recurrence. The MRI, as I explained before, T1 hyperintensity is related to the hemorrhage in the ablation zone, versus T2 VIBO hypointense. But if there is a new onset of T2 hyperintensity, then we will take it as a tumor recurrence. So this is an appearance of a recurrence. PET has no role, so don't bother with it. In fact, it confuses. Thanks to Santosh, I learned it as well. The new scan, which is available using the PET as a modality, using an antibody, which is monoclonal antibody, which is tagged on, and it is particularly useful in the follow-up of the clear cell variant. It is not useful in the other variant, but it cannot differentiate the other cancers. So that is the only new thing that is available in the system. Imaging will also be useful in the post-ablative setting for finding out hemorrhage, bowel injury, collecting system injury, etc., etc., etc. So CT and MRI plays a pivotal role in assessment of treatment efficacy. The hallmark of the success is absence of enhancement and the formation of a halo. In the post-treatment setting, a new onset of a nodule, new onset of an enhancement should be suspicion of a recurrent disease. But whether the long-term follow-up and what exactly the modality we should do, how often we should do, those we need to learn only with the time. Thank you so much for the opportunity, Santosh.
Thank you, Dr. Raghavan, and Dr. Ganesh for the comments, please.
Thank you very much, Santosh. Let me confess that my knowledge on this subject is zero. I have no experience, and I've just sort of been reading what is written in good English, and I'm trying to put it in bad English, as our Guru HSB would say. In our country, I have not heard anybody speak on this at any urology conference. But I know for a fact that there are certain radiologists I know in the city of Kolkata who are actually doing RFA. And RFA is being done by some other people for the liver, etc. So the only thing that I would like to emphasize on this particular subject is that the process of healing is slow. It takes a lot of time. Tumor ablation can take in 6 months only 30%, and sometimes as long as 3 years, you may get only 75% reduction. As Raghavan has said, the periphery is the one that's more important, and if there are changes there in the periphery with enhancement, then you would get an index of suspicion that maybe there is. And some people have actually gone and biopsied this. The reason why it is there in the periphery is because when you use RFA and cryo, it is a spherical reaction. And all the tumor is pushed towards the periphery. And therefore, if you look at anything, it will be only at the edges of this lesion and not anywhere else in the center. All the complications that are listed for any form of surgery can occur also with these treatment modalities. So let's not be blasé about saying that, yes, this is a simple treatment. No, it has got its own set of complications. And what I would suggest is that I would recommend you to read this book. If I don't know where you can see it. Radiology and Follow-up for Urological Surgery by Chris Woodhouse and Alex Kirkham. It's a great book. I think every resident must read it, and every department of urology must possess this book. It's very cheap and effective, and what I've learned on this subject is directly from this book. So thank you very much, Santosh, for the opportunity.
Thank you, sir. Thank you, sir. This was in my EAU meeting that I actually heard a lecture and a small comment in a lecture, after which I came and studied on this. And then I had a vision to do this topic. Okay, thank you very much. And now we have Dr. Anuradha, who will be talking on imaging in adrenal gland with CT scans. In the past, we've been using more of MRI, and now the CTs are better. Dr. Anuradha is a professor of urology at CMC Vellore. She's the lead for abdominal imaging, and she has been trained in the UK and US. And we are glad that she is with us, and she'll talk on this topic. Okay, over to you, Anuradha. Yeah, we can see your slide, but we can't hear you. You can unmute yourself. Anuradha, we can't hear you. Can you please unmute yourself?
Okay.
Yeah, we can hear you now. Please start.
Yeah. Thank you, Dr. Santosh, and very good evening, everybody. So adrenal lesions are extraordinarily common in our practice, and almost 4 to 10% of radiology studies performed for unrelated conditions will show an adrenal nodule. And among all the adrenal nodules that we see in practice, majority of them are non-functional, and very few of them are functional, and they may be symptomatic because they are pheochromocytomas. They may present with palpitations and hypertension. They can present with Conn syndrome, Cushing's, virilization if it's an ACC. They can be associated with syndromes, and they can be a part of some genetic mutations associated with multiple pheochromocytoma. The third clinical scenario where we see adrenal lesions is in a setting of known malignancy, and imaging performed during any part of cancer care, staging, restaging, or surveillance can show us an adrenal lesion, and we'll be asked to commit whether it is a metastasis or an incidentally detected lesion. With this background, an adrenal protocol that we normally would do is a plain CT scan through the adrenal gland, which is about 3 millimeter thin sections of the adrenal, viewed in both axial and coronal planes, an arterial phase image, a venous phase image, done 20-second and 70-second after the start of contrast injection, and the delayed phase images obtained 15 minutes after the injection of contrast. But this adrenal protocol and the adherence to this protocol is very much dependent on the referral pathway, whether the patient has been referred knowing that there is a clinical suspicion of an adrenal lesion because of symptoms present, or was it just done, incidentally detected on a scan done for unrelated imaging, unrelated pathology. So what the radiologist first will look for is to try and recognize whether the adrenal gland is normal or abnormal. Our own work from our department has shown that the normal thickness of the body of adrenal gland measured at this point in this fashion is about 7 millimeters, and the thickness of the limb is approximately 4 millimeters. But in this example, when we see this kind of attenuated adrenal gland, we can think of an autoimmune adrenalitis. On the other hand, when there is bilateral adrenal enlargement in this fashion with low density areas, we would think of granulomatous infections like tuberculosis or histoplasmosis. The next question that we would ask is, what is the size of the adrenal lesion that is detected? Is it less than 1 centimeter? If so, if there were no symptoms and it was incidentally detected for an evaluation for some other disease, there is no need for follow-up of those lesions, which are less than 1 centimeter in size. But if the lesion is greater than 1 centimeter in size, the radiologist will first see whether there are definitely benign features in the adrenal lesion. And second, review the post-contrast images to determine if this lesion characterization was complete, or did the lesion is it just indeterminate even at the end of assessing post-contrast images? And also we will look to see whether the abnormality that we're seeing on CT is unilateral or is it bilateral. If it's a bilateral adrenal abnormality, this is the list of conditions that will go through the minds of a radiologist by trying to narrow down the differential. So what are the definite benign features? Definite benign features include macroscopic fat, a CT attenuation value of less than 10 Hounsfield units on plain CT, demonstration of lack of enhancement of the lesion by saying that there is no difference in the attenuation value between pre and post contrast images, or the difference was less than 10 HU, and if it is a cystic lesion. So differentials when there are definitely benign features would include a lipid-rich adenoma or a myelolipoma, which will have a macroscopic fat, or a cyst which will be of water density that is less than 20 Hounsfield units, hemorrhage which will have a Hounsfield unit of greater than 70 on plain CT, benign calcification, and demonstration of temporal stability over 2 years duration are all features which are definitely benign. So in that, so this is an example of a classic adrenal myelolipoma, which is a well-defined heterogeneous lesion with macroscopic fat and soft tissue density areas from myeloid component. When an adrenal myelolipoma is greater than 4 centimeters, like in this example, we will bring this finding to the impression because when these lesions are greater than 4 centimeters, they can bleed spontaneously, and the surgeons may want to consider surgery to prevent such a complication. This is an example of another definitely benign lesion with a Hounsfield unit of less than 10 on plain CT, 2 different examples of lipid-rich adenoma. When we see these kind of lesions, it's definitely benign. Similarly, is an example of an adrenal cyst, which has an attenuation value of less than 10 in all the different phases, the plain, venous, and the delayed phase. Though the attenuation value is different on these three set of images, the difference is less than 10 HU, so it is still a non-enhancing lesion and an adrenal cyst, which was again proven on this ultrasound image, which shows a anechoic, well-defined cystic lesion in the adrenal gland. After looking for benign lesions, radiologists know that the most common adrenal incidentaloma is an adrenal adenoma. So the review process to exclude an adrenal adenoma starts with the plain CT. We'll first look at the attenuation value because we know that it's got very high specificity for identifying a lipid-rich adenoma. But 30% of adenomas can be lipid poor. If it's lipid poor, what we will look at is the washout characteristics, which is an absolute washout of contrast, which takes into account the attenuation value of plain CT as well. It is the difference of venous phase image minus delayed, and the ratio is between this difference and the difference between venous phase and plain CT scan. When the absolute washout of contrast is greater than 60%, or a relative washout of contrast is greater than 40%, then the accuracy for determining adenoma is very high, as shown in this slide. But I want to drag your attention to what happens when the delay is not 15 minutes. When the 15 minutes delay, there's a lot of problem with sticking to this time because of workflow issues in a CT room. And if the delay is reduced to 10 minutes, we need to reduce the threshold to 52% washout to maintain the diagnostic performance for identifying adenomas. The capability of contrast-enhanced images for diagnosing adenomas is because we know adenomas will rapidly pick up contrast and will wash out the contrast rapidly, whereas malignant lesions will retain its contrast for a long time. So taking advantage of this difference in the washout characteristics will help us diagnose an adenoma. This is an example of adenoma in a patient with Conn syndrome, where plain CT itself gave away the diagnosis that it is a lipid-rich adenoma. But even when we look at the venous and delayed phase images, we can see that the absolute washout is greater than 60%. Another example of bilateral lipid-rich adenomas, which is not uncommon. Again, in this case, the patient presented with a Conn syndrome and a bilateral adrenal adenoma. Left was subcentimetric, right was about 14 millimeters, and this patient underwent bilateral removal of adrenal adenomas. In this example, a 33-year-old female patient had occasional palpitations and was referred to exclude an adrenal mass, but urinary VMA was normal. When we look at the attenuation value on plain CT, it is greater than 10 HU. On the arterial phase, it was 120. In the venous phase, it was greater than arterial, it was 130. And in the delayed images, it was 100. So the absolute contrast washout was 33% and relative was 23. So it is not in the range of an adenoma, but VMA was normal. So what would we do next, and what would be our differential diagnosis? Differentials would be a lipid-rich adenoma, pheochromocytoma, adrenal cortical carcinoma, or metastasis. We did an MRI for further characterization of this mass. An MRI showed no fat within the lesion. The opposed phase images are supposed to show drop in signal of the lesion, but that was not present. And the mass was heterogeneously T2 hyperintense. This is a typical appearance of paraganglioma, and this turned out to be a metanephrine negative dopamine secreting paraganglioma. So do not go and biopsy lesions directly. Using MRI will be of value. A pheochromocytoma, as I said, can have a washout characteristics which is not like that of an adenoma, but a third of pheochromocytoma, like in this example, will have an absolute and a relative percentage washout, which is in the range of an adenoma. So how do we then recognize pheochromocytoma? By looking at what is the attenuation value in the arterial and venous phase. the maximum attenuation value when it is greater than 110, heterogeneous enhancement, and a large lesion will help us diagnose pheochromocytoma rather than an adenoma, even if the washout characteristics are like that of an adenoma. The other mimics of an adenoma in terms of washout characteristics would be a hypervascular metastasis from RCC, hepatocellular carcinoma, melanoma, neuroendocrine tumors. These things would mimic the washout characteristics of an adenoma, and it's important to keep a watch on what is the maximum peak attenuation of that particular lesion to be able to suggest alternative diagnosis such as pheochromocytoma or a metastasis. And also, it is important to realize it's the peak enhancement of the lesion and not a particular phase to diagnose a pheochromocytoma. I've given you 3 examples here where the attenuation value and the degree of enhancement is very variable. So the peak enhancement of a pheochromocytoma varies across different phases, with about half attaining peak enhancement in venous phase. So when the peak enhancement is greater than 110, we need to suggest that pheochromocytoma is a possibility, and doing other biochemical tests would be useful. This is an example of how pheo is associated with syndrome. This is a patient with MEN 2A associated with medullary carcinoma, thyroid, and the parathyroid adenoma. In this patient, there are multiple neurofibromatosis on the skin, and this is a pheochromocytoma in the right side. And similarly, this is a patient with VHL with bilateral pheochromocytomas, RCC, pancreatic cyst, cerebellar lesion, and a retinal hemangioblastoma. When there is a known primary, the imaging modality of choice to exclude an adrenal metastasis is PET-CT. PET-CT has about 94% accuracy in correctly identifying adrenal metastasis. So this is an example of a lung cancer with left adrenal metastasis. This is an example of a very large mass in the right adrenal gland with a small punctate calcification in a patient with ACC. In a young child with ACC, also had a extensive IVC thrombosis extending into the right atrium. Usually, adrenal cortical carcinomas, as seen in this example, are greater than 6 centimeters in size. When all these diagnoses that I showed so far can be diagnosed by the radiologist, but there would be these tricky situations where this mass is greater than 4 centimeters, but the attenuation value and the contrast washout will not help us take the lesion further. So this was an adrenal ganglioneuroma at surgery, which will be impossible for a radiologist to offer a diagnosis. And similarly, this is an adrenal myelolipoma. Sometimes adrenal myelolipomas will have very little fat, and it will be difficult for us to suggest this diagnosis. In this example, a massive bilateral adrenal myelolipoma was mimicking a liposarcoma, and again, it will be difficult to give a specific diagnosis in these patients, and we need to offer differential diagnosis. A sarcoma mimicking an adrenal mass, and retroperitoneal teratoma mimicking an adrenal mass. In this case, you can see a tooth and macroscopic fat, and rarely mass that is not arising from the pancreas, like adrenal, such as a pancreatic mucinous adenocarcinoma, like in this example, can mimic an adrenal mass. And lastly, this gastric diverticulum, posterior gastric diverticulum, in this particular example, we were lucky that there was an air pocket, but very often posterior gastric diverticulum will have fluid filled within the diverticulum, and it can very much mimic an adrenal lesion. So with this, I want to say a radiologist will approach an adrenal CT in this fashion. Adrenal protocol will be dependent on the referral pathway. Size is very important in trying to predict what we should do with this lesion next. And we'll look at the number of lesions, laterality, and we'll also look for, first thing we'll assess in an adrenal lesion is there benign features? And then is it an adenoma? We'll ask ourselves, is it an adenoma? Is it a pheochromocytoma? Is it a metastasis? Is there a known cancer? Or is there a previous to compare to establish temporal stability and interval growth? And in spite of all these steps, a handful of them will be indeterminate. So what is new in adrenal CT? Dual energy CT, when there is protocol issues because it's incidentally detected, now through using dual energy CT, we can subtract the iodine from a contrast enhanced image and then calculate the attenuation value on plain CT to say whether this lesion is an adenoma. And so along the similar line is this photon counting detector CT, which can subtract the iodine from the scan and also will help us do a material decomposition. You can separate, you can identify the quantity of fat in the lesion, microscopic or macroscopic. You can assess the quantity of iodine in the lesion. And so there'll be more accurate prediction of lesion characteristics with these. And finally, radiomics is the hot topic in radiology. We're using that to characterize every possible thing. Thank you very much.
Thank you, Dr. Anuradha, for that exhaustive. I think everybody would have learned something. Unfortunately, Dr. Amlesh Sheth is not with us, who was supposed to be the commenting doctor to comment on this, but Dr. Ravi Mohan has kindly consented to pass his comments. So over to you, Ravi.
Thank you, Dr. Santosh. She's the only radiologist in the group, so whatever she says is the final word. So I will take her in fact, the reason I agreed to give a comment was not to comment, but to understand the imaging better, and I learned a lot. Thank you, madam, and thank you for explaining it very clearly, how to differentiate a benign versus a malignant versus a FEO versus a syndrome, and the areas where there are dilemma situations. Thank you very much.
Thank you, Dr. Ravi. We all move on to Dr. Nayak. Now, Vi-RADS has come for treatment of bladder cancer, and I have requested him to not only talk about the evolution of the Vi-RADS for bladder cancer, but also to see whether he could tell us about some novel uses of the use of Vi-RADS in managing bladder cancer. Over to you, Dr. Nayak.
Can you see the full slide, sir?
Yeah, please go on. We can hear you and your slide is full screen.
Thank you, USI, and thank you, Dr. Santosh, for inviting to speak on this forum. The topic was the evolution and novel indications of Vi-RADS in bladder cancer. When Dr. Santosh actually asked me to speak on this, I was actually thinking, what should I speak? Because normally I do not prefer a MRI over CT scan for evaluation of bladder cancer. Routinely we do not do. So I was little bit skeptical whether I should speak on this or not. But then I started reviewing the literature, and I'll just speak how the Vi-RADS come into the picture and what are the specific indications where actually MRI might help in certain situations over a CT scan. So Vi-RADS actually stands for a vesicle imaging reporting and data system. It is a structured reporting scheme for multiparametric bladder MRI, and it is used for the evaluation of bladder cancer, and the evolution actually started in 2018. As we all know, the current standard imaging modalities for bladder cancer is ultrasound abdomen and CT abdomen, sometimes an MRI abdomen with urogram. However, these imaging modalities have limited performance in assessing the muscle invasion. Hence, ultimately to distinguish between non-muscle invasive bladder cancer and MIBC, the unconventional imaging still remains a challenge. So we ultimately rely on the TURBT, which remains still the gold standard for the staging of the bladder cancer, to decide the future course of the treatment. MRI has been investigated for many other cancers extensively, unlike that in bladder cancer, and it has a remarkable results due to its high soft tissue contrast resolution and the multiplanar imaging capabilities. However, there is significant disagreement among the radiologists itself in reporting muscle invasion on routine MRI. But the introduction of multiparametric MRI with the combination of anatomical and functional sequence has to a certain extent overcome this particular issue. And there are many reporting and data systems are already in use, like in Vi-RADS for prostate cancer, Vi-RADS for breast cancer. So in 2018, Panavienko et al. Proposed a novel standardized approach for bladder cancer imaging called the Vi-RADS. And it is for the better assessment of the bladder lesions and to reduce the disparity among the radiologists' observation by giving it a more objective approach. So the Vi-RADS scores, this was assessed by taking into certain categories like the structural categories on the basis of the titubated imaging, and the diffusion-oriented category on the basis of diffusion-oriented imaging, and the contrast enhanced category on the basis of the dynamic contrast enhancement imaging. So this was originally designed for untreated bladder cancer, basically for the staging of the pre-TURBT setting. However, it has still very low uptake among the urologists and even also among the radiologists. So the scoring, Vi-RADS scoring was depending upon the structural category, contrast enhanced and dynamic diffusion-oriented category. The scoring were given like 1 to 5 in each category, and the mixing of all these three categories finally gives to the Vi-RADS scoring of 1 to 5. Where Vi-RADS 1 was muscle invasion is highly unlikely. Vi-RADS 2 is muscle invasion is unlikely. It's like you have to look at the first is highly unlikely, second is unlikely, the third is muscle invasion is equivocal, fourth is muscle invasion likely, and the Vi-RADS 5 is highly likely of the muscle invasion. So these scorings are basically the structural category. The scorings are when they give the scoring, they typically take into account the lesion size of the lesion, whether it is less than 1 centimeter or more than 1 centimeter, whether it is an exophytic tumor with a stalk or it is a sessile tumor, and also they look at the interruption of the signal line representing the integrity of the muscularis propria. So by taking into account all these factors, they give the score from 1 to 5. So the multiparametric MRI for the bladder cancer that you heard, as I told you, you heard in the year 2018. In this particular review, the Panabionka actually what he said, they do not advocate multiparametric MRI with Vi-RADS for all patients with bladder cancer, but this imaging might complement the pathology, pathology like muscle invasive or non-muscle invasive, which was T1, G3 or T2 or T3, and it reduces the radiation-based imaging like CT scan. But the most important useful indications for Vi-RADS, what they suggested is the non-muscle invasive bladder cancer, where it can actually expedite whether the patient should be following a conservative path for intravesical therapy or the patient should be given a radical treatment. So that was the most important indication that said to decide regarding the non-muscle invasive treatment management, and also for determining the response to the bladder sparing approaches like patients those who are receiving NSCT, or to decide whether those patients they opt for upfront trimodality therapy after diagnosis for T2 muscle invasive bladder cancer. So these are various studies on the Vi-RADS to evaluate the performance of the Vi-RADS in predicting the muscle invasion. If you look at this, there are some original article and there are some meta-analysis. The sensitivity and specificity of the Vi-RADS in predicting muscle invasion is from 80% to 95%. It's in the range of that. It's a very good sensitivity and specificity to decide the muscle invasion. If the Vi-RADS scoring is more than equal to 3. This is another preliminary report on Vi-RADS to assess the response to systemic therapy like neoadjuvant chemotherapy. In this particular paper, what they found, patients those who are getting neoadjuvant chemotherapy, and after that to assess the response to chemotherapy, when those patients ultimately undergo radical cystectomy and multiparametric MRI with Vi-RADS, whatever the response that the scoring they have given, whether the patient has a residual lesion, whether there is no residual lesion, there is a pretty good correlation with ultimate final radical cystectomy histopathology. So Vi-RADS is actually very good in predicting the disease response in neoadjuvant chemotherapy, which actually ultimately sometimes can decide, because with the advent of this neoadjuvant chemotherapy, there are patients those who completely respond. There is complete radiological response to decide whether those patients sometimes, because many of those patients say if there is no disease, why should you undergo a cystectomy? So that's an area of interest that's coming up. So to decide who are those patients, those should be actually kept under surveillance, or those who should undergo a cystectomy, Vi-RADS can actually come into play in those particular situations. This is a meta-analysis and systemic review. Again, this actually said the diagnostic performance of Vi-RADS to determine the pre-TURBT staging is pretty good. And there is a wide reliability of the Vi-RADS accuracy among different centers, even with different level of experience. actually underlining the importance that the standardization and reproducibility of the Vi-RADS in multiparametric MRI. So the important question is, even if the Vi-RADS actually is very good in telling if muscle invasive or non-muscle invasive, the treatment of bladder cancer ultimately we rely upon the histopathology, then finally decide what to do. So where actually the Vi-RADS can help in deciding the treatment plan. The potential indication will be in initial bladder cancer risk stratification, the response to neoadjuvant therapy, and in primary bladder sparing approach like trimodality therapy. So if you look at the bladder cancer risk stratification, the ability of urologists to discriminate between the stage and grade only on the basis of the cystoscopy is relatively good. The literature has actually shown the projective predictive value to predict if it is a low grade or high grade on the basis of cystoscopy is 85% and 71% among the urologists. And also to discriminate between non-muscle invasion and muscle invasion, it is up to tune of 93% or 85% on the basis of only cystoscopy. So by adding MRI to cystoscopy might enhance the diagnostic ability. So in future, it might actually come, people might say, like in RCC, but actually we do not need any biopsy to decide whether the patient should undergo a radical or partial nephrectomy. Can it be a situation that one should do a cystoscopy and then do an MRI and finally decide the patient should undergo a radical cystectomy without doing a TURBT? Whether that will come in future, that we will just see. But the important indication, the specific indication I will speak now, the accurate pre-TURBT identification of patients to decide TURBT. In a TURBT, suppose histopathology came as if it is a less than 3 centimeter tumor and the histopathology came out as T1 disease, T1 high grade disease. As per the guidelines, all these patients should actually undergo restage TURBT. But suppose if you do a Vi-RADS in pre-TURBT and the Vi-RADS scoring is 1 and 2, and it is a small single lesion less than 3 centimeter, it is T1. Whether this patient should again undergo a restage TURBT and delay their intravesical therapy, or since the Vi-RADS actually shows it's only a 1 or 2, there is very high unlikely of this getting upstage. So we can expedite the intravesical therapy without actually wasting time in restage TURBT. The other scenario will be if there is even if that is a small T1 tumor, the Vi-RADS shows it's 4 and 5. So in those cases, it becomes actually an imperative indication. Maybe the Vi-RADS actually come into play in this particular situation. And another situation will be with patient with the primary TURBT if there is a multiple T1G3 lesion. Since there is now more and more studies and coming more and more indications for early cystectomy in T1G3 disease, if the patient is having a multiple T1G3, if the pre-TURBT, the Vi-RADS shows it's 4 and 5, maybe those patients can be counseled for early cystectomy rather than doing a conservative approach. So this is again another important article. It's not actually an article, this was an abstract. So it's presented in ASCO 2020. This was from UK. Here they are actually talking about replacing TURBT with multiparametric MRI to decide regarding the management of the muscle invasive bladder cancer, even decide cystectomy on the basis of only MRI, replacing the TURBT. So this is a paper, this is a study that randomized trial that's going on in the UK. So I'm not going into the details, but let's show it what the study actually tells in the end. So like I told you regarding partial and radical nephrectomy on the basis only on the basis of imaging. So then the response to neoadjuvant therapy, we know that there are complete pathological response after neoadjuvant chemotherapy. This has raised the questions regarding the potential bladder sparing. However, if you do only TURBT after complete radiological response, TURBT actually falsely downsays 32% of cases, and it can reliably predict T0 only in 47% of the cases. So maybe by adding MRI to these patients, one can actually decide if the suppose MRI shows there is no disease in the bladder and the TURBT shows it's T0, can we then potentially ask this patient to be on surveillance rather than undergo cystectomy? So Vi-RADS may come into the picture in this scenario also. And finally, the patients, those who are opting for trimodality therapy upfront, MRI might actually help better by discriminating much better than CT between T2 and T3. If the MRI can better predict this is a T3 not T3, maybe T2 patients are better suitable for bladder sparing approach by trimodality therapy. The potential issues, it was primarily evolved for untreated or pre-TURBT bladder. Most of the cases actually we get, patients are already undergone a TURBT outside, they get referred. So now there are data that's coming on emphasizing the role of MRI and Vi-RADS scoring in differentiating inflammatory and post-surgical changes from the malignant changes. Another important aspect is no importance is being given to the hydronephrosis, which is an important predictor for muscle invasion in CT scan. In Vi-RADS scoring, hydronephrosis has not been taken into account. So the take-home message is Vi-RADS scoring is to standardize the imaging and reporting for bladder cancer to not to have differences among the radiologists, and the potential indication, as I told, to decide regarding the restaging, and it can be incorporated into Kyoto, URTC or EAU restratification to improve the accuracy of these prediction models, maybe to monitor the response to neoadjuvant chemotherapy and decides the bladder sparing, and sometimes in patients those who are opting for upfront bladder sparing treatment. Thank you.
Hello. Hello.
Yes, now
Dr. Jagdish, yeah, please.
Yeah, good evening. Thank you very much for asking me to comment on this. And I'm very impressed with the, the data presented and the information presented by Dr. Nayak. Actually, almost making me believe that we will have to change our mindset from CT scan imaging to MRI in the, in future, or maybe immediately for that matter. Having said that, there are a couple of issues which I wanted to highlight. One was there has been no data or information on CIS, carcinoma in situ, especially in non-muscle invasive bladder cancer. And of course, you really said that if you have to have a bladder sparing approach, MRI should be done. Well, certainly, yes, I agree. The other issue is there are patients or say clinical settings where patient cannot be given contrast. And I think Vi-RADS will come very handy in that way. Thirdly, and most importantly, will be concomitant finding of a prostate cancer, which is, if you believe the data is 1 in 5 or occult cancers in the prostate, we will be in for that, especially in the regions where in trigone, where we are not sure whether it's a primary prostate or primary bladder cancer. Perhaps the Vi-RADS will come into way. And I agree with you that Vi-RADS is for tomorrow, maybe even today for that matter. And I think we will have to change our mindsets to start using Vi-RADS as a primary investigative. Of course, the trials will come up, the data will come up, but I think it's worth noting that well, we should think about Vi-RADS. And thank you very much for the information.
Thank you, Dr. Jagdish. Actually, the introduction I gave was the youngest Uro oncologist. Unfortunately, my mic was on. And now we go to the next one. Can biopsy be avoided based on imaging in carcinoma prostate? And Dr. Girdhar Bora from PGI Chandigarh. This is the whole topic will be covered by PGI only. Okay. So over to you, Dr. Girdhar.
Thank you, Dr. Santosh. Am I audible and my slides are visible?
Sure. Yeah. Carry on.
Outside, I'd like to thank the Uro Oncology subsection of USI, Dr. Santosh, Dr. Sabnis, Dr. Ravi for this opportunity. And today I'll be discussing the role of imaging in prostate cancer, whether the imaging has improved so much that we can avoid biopsy in prostate. I have nothing to disclose, but I was a part of the prostate cancer imaging group when I was in AIIMS New Delhi, and we published a good number of papers of MRI in prostate cancer. Now coming to prostate biopsies, it is the most common urological procedures performed worldwide with more than 1 million biopsies done every year. And it is very crucial in diagnosis of prostate as well as planning further management based on the biopsy. However, biopsy is associated with significant complications and a good number of patients undergo unnecessary biopsy for a low risk disease. And coming to biopsy complications, pain and bleeding are frequent, and there is now the risk of infection is increasing over the years following prostate biopsy. A lot of patients experience urinary retention and worsening of their lower urinary tract symptoms following biopsy. And biopsy is also associated with significant anxiety and psychological burden to the patients. Therefore, we are looking into a pathway where we can avoid biopsies in patients. Now, with the improvement of imaging, MPMRI is now being increasingly utilized for management of prostate cancer. And according to the recent trial, the MRI's targeted biopsies improved the detection of clinically significant prostate cancer and has decreased the number of insignificant tumors diagnosed at the biopsy. And various trials on MRI first, precision and forum trials have shown that a lot of patients have a negative MRI, and probably these patients can avoid biopsies if they have a negative scan. However, the MRI has very significant inter-observer variability, and the positive predictive value is very low. And if a patient is having a negative MRI, he still can miss a prostate cancer up to the tune of 10%. To improve the positive predictive value of PSMA PET scan and to increase the negative predictive value, now people are utilizing adding PSMA PET scan to the MRI, and studies have shown when we use PSMA PET scan along with MRI, it has improved the sensitivity and specificity of the imaging significantly. Now coming to what all potential scenarios where we can avoid biopsies in prostate cancer, and we also published our data where the clinical implication of MPMRI comes in. And when the patient comes with an initial increased raised PSA or a normal or abnormal DRE, at this stage, can we avoid few patients where we can say based on imaging that they are having a very low risk of harboring a prostate cancer and they can probably avoid biopsy. Another subgroup is when the patient is already diagnosed a low risk prostate cancer and he is on a follow-up, on an active surveillance, and according to the active surveillance protocol, he has to undergo biopsy every year. And can we avoid biopsies in this subgroup of patients based on imaging? This is one of the important scenarios. And recently, when the imaging is confirmatory of prostate cancer based on PSMA PET scan or MRI, can we straight away directly take these patients for radical prostatectomy without doing any biopsy? So we'll be discussing all these scenarios, how imaging can avoid biopsies in such scenarios. Now coming to the first scenario, avoiding unnecessary biopsies. The largest study on this thing is a PROMISE trial, and they have looked into that whether based on imaging we can identify the patients who can avoid biopsy, and they have included 576 patients. All the patients underwent MRI and a TRUS-guided biopsy, and they found that 158 patients had negative MRI, and probably these patients can avoid biopsy if they have a negative MRI. However, when biopsies was done, there is a risk of missing significant prostate cancer in 17% of these patients, 17 patients in this group, and the negative predictive value of MRI came up to the tune of 89% in this study. And we also looked into our data of prostate cancer biopsies at AIIMS New Delhi, and we found that the ADC values were significantly different between low-grade disease versus a high-grade disease, and we showed that the pre-biopsy MRI can stratify the prostate cancer aggressiveness non-invasively, and it's correlated with the biopsy. And men with a low risk of low risk tumors on MRI can avoid biopsy in a scenario. Now, again, further to increase the MRI specificity and sensitivity, PSMA PET scan was included, and this combination was studied in a prospective fashion in a 296 patient in a primary trial, and they found when the combined PSMA MRI was used, there were 51 negative patients which would have avoided the biopsy. However, there is a risk of missing clinically significant prostate cancer in 5 patients. And adding PSMA therapy to MRI has improved the negative predictive value from 72% to 91% in their trial. Now, another scenario is avoiding biopsy in active surveillance. The largest study on active surveillance is PRAYAS study. They have included more than 5,000 patients across 18 countries, and they found that at 5 and 10-year follow-up, significant number of patients discontinue active surveillance. They choose for a definitive therapy. And to increase the number of patients who can continue on AS, they have changed the protocol, and they found that MRI has a 100% negative predictive value of Gleason upgrading in patients of active surveillance. And they found that the trigger that if the patients are having more than 2 core positive, where initially used to go for a definitive therapy. Now they have changed it to do a MRI and rebiopsy only when there is a MRI upgradation in such patients. And we also looked into our data set of patients of 116 patients, and out of that there were 9 patients were showing high-grade penile lesion in our study. And we looked into their ADC values, and whenever their ADC values came down, and we found that there is a progression of the disease, and we biopsied 5 such patients and found to have a significant prostate cancer. And we have shown that MRI could predict future detection of prostate cancer in men with initial negative prostate biopsies. And the third scenario, it is new in this topic. When the imaging is confirmatory of a prostate cancer, can we avoid biopsy, and we can directly take them for the radical prostatectomy? Why we want to avoid biopsy before radical prostatectomy? Because when you do a biopsy, there will be a certain post-inflammatory change that will make the tissue planes very difficult, and we will not be able to do a good nerve sparing. And also there is a chance of high positive surgical margins, and there is associated increased cost with the biopsy, and probably higher than the doing a PSMA PET scan. And also biopsy related complications can be avoided. And generally we will have to wait from biopsy to radical prostatectomy for 4 to 6 weeks. This time can be reduced, and reducing this time will potentially decrease the psychological burden and anxiety in these patients. And recently a series of 11 patients were published, and they have done MRI as well as PET scan in these 11 patients, and without biopsy all these patients were taken up for a radical prostatectomy, and they found only 1 patient as a benign lesion. The rest all patients had a prostate cancer in their series. The other issues in this series, they have 2 patients have a clinically low risk disease who underwent radical prostatectomy because the patient was not undergone a pre-radical prostatectomy biopsy. Coming to the primary study again, the primary study was initially designed to detect the patients who can avoid biopsies. However, in their subset analysis, they found that patients who are having a more than 4 pirates lesion on MRI and a SUV max of more than 8.7% in their PET scan have 100% specificity to diagnose a clinically significant prostate cancer. And based on this primary study, a retrospective analysis was recently published in European Urology, where there 25 patients in their group underwent MRI as well as PET scan. And all the patients have MRI pirates more than 4 lesion and a PET score of more than 4 points. No patient underwent prostate biopsy, and with adequate counseling, all the patient underwent radical prostatectomy, and all patients found to have a clinically significant prostate cancer in these patients, and showing the specificity and positive predictive value of imaging up to the tune of 100%. However, there are certain issues of not doing biopsies before radical prostatectomy, because the risk of radical prostatectomy should be weighed against the prostate biopsy, because there will be a possibility of unnecessary surgery in these patients. There are potential complications and side effects of radical prostatectomy like incontinence, erectile dysfunction. And also patients cannot be given options of radical therapy or radiotherapy or focal therapy because the biopsy is not available. And such patients are very few and a very select group of patients who can undergo radical prostatectomy based on imaging. To conclude, MRI and PET scan are improving day by day, and they are aiding in deciding the need for therapy. Still, the negative predictive value is not 100%, and there is a still risk of missing prostate cancer when biopsy is not done based on imaging, and it is still not in a standard protocol. And radical prostatectomy without biopsy is an evolving concept and needs more validation, and patient counseling is critical before embarking on radical prostatectomy without biopsy. Thank you.
Thank you very much, Dr. Girdhar, and I request Dr. S.K. Singh to please give the remarks on this. Dr. S.K. Singh, please. We can't hear you.
Yeah, somehow I'm getting some connection. Thank you. Sorry for that. Actually, the topic was given to me. I can understand. When the case is, you think it's just CA prostate, can you avoid biopsy? So Dr. Bora has elaborated all the points very nicely. What I have to add is that when can we avoid biopsy in CA prostate? When you see the patient PSA is high and there is fulminant metastasis proven by imaging like PSMA PET, I think very well we can avoid biopsy in such cases. because there's a risk involved and it's not going to add much to the benefit of the patient. Second situation I can see clinical scenario is the patient is taking anticoagulant for acute cardiac problem or for DVT due to lymph node metastasis. You have proven on the PSMA PET that yes, the patient has got metastatic disease or maybe locally advanced disease, maybe biopsy provided for the benefit of the patient. Now, regarding the early diagnosis, what I can see, when we can do staging with PSMA PET, when we can do local recurrence, we can detect with the PSMA PET. Why can't we say diagnosis also for primary disease, primary lesion in the prostate? Now, Dr. Bora has nicely told that when the MPMRI has shown period score 4 and more, and the PSMA PET score more than 4 or equal to 4, that is more than salivary gland or equal to salivary gland, maybe biopsy can be avoided. But the onus falls on the treating urologist. Now, nobody will accept. One side, you are thinking the benefit of the patient, but same time, you have to protect yourself from litigation. What in our study we have shown, out of 78%, 56% were found to have PSMA lesion. And 54 of them, out of 56, were found to have cancer prostate. And in 2, it was prostatitis. When we reviewed the history of those 2 patients, because PSMA was high, the patient has every reason to think of prostatitis. Clinician could have thought of. So I think the specificity of PSMA is very high. It is the clinician who had to decide when to avoid again biopsy. But again, the counseling is important. You are doing for the patient, so you think of the benefit of the patient. When you do both the things combined, PET as well as MPMRI, the cost involved also need to be analyzed. Maybe patient may tolerate biopsy 1 and 2 needle, because with the help of PSMA PET, only targeted biopsy is enough for establishing the diagnosis for early cancer prostate. So I say ultimately the onus falls on the urologist, treating urologist, and then you have to counsel the patient when you are deviating away from the standard of care. What I'm trying to say, when metastasis can be thought of by the based on PSMA PET, local recurrence again is detected with the PSMA PET. Why not for early diagnosis of prostate cancer? For early treatment of prostate cancer also, we can rely on PSMA PET, which is very specific. The clinical scenario has to be taken into consideration. Thank you very much for giving time at the fate of the time. At the same time, but getting disconnected. Fortunately, I was trying in the mobile, but I could make it on the line, and then I am connected to all of you. Thank you, Dr. Santosh. I think this program was very excellent, and I have done my job. Thank you very much.
Thank you very much. I know there might be a lot of questions, and if time was there, we could have gone, but we promised that we'll finish in 1.5 hours. I'm sorry that we are maybe 5-7 minutes late, and I just request Dr. Sabnis to give the concluding remarks, and then we'll close.
Yes, thank you, Santosh, for organizing this particular webinar in a very fantastic way. I think the theme which you have selected, that it's an image-based discussion and topics, was quite successful, because a lot of concepts and a lot of misconceptions are cleared by this various talks. Some of the talks were quite stimulating. The role of PSMA in a coming years. Role of PET scan itself is being questioned and is being clarified. The last talk was quite thought-provoking, whether we can really avoid the biopsy or not. So these are the topics which are very, very relevant, and I'm sure they are the stimulus for the future discussion, future thought. And these are the things which are actually research, and the new research is going on. So I must congratulate you for selecting this team, and not only sorting out a nice, good program, but finishing in proper time. 5-7 minutes is perfectly all right. It is by our standard nothing. It is perfectly on time. So I must congratulate you for this particular webinar. And I must congratulate all the other conveners who are also logged in, and the hard work which you people are doing for the benefit of the oncology, progress of the oncology section of USI. So with this word, I conclude, and thanks everyone for joining. I think there were a lot of participants for a long time, and an important part of this webinar is that all this discussion and thing is there in the archives. So moment they visit the archives, everything is classified in a date-wise manner, topic-wise manner. And therefore, a lot of people, we have got feedback that when they have a leisure time, when they are traveling, they just open and of that area of interest, they keep on watching these archives. So apart from the people who have actually logged in, it is important that this discussion is stored, archived, and then it can be watched anytime when there is a leisure time. So once again, thank you very much.
Thank you very much, everybody, all the speakers, all the experts and everybody. Please have a great night's sleep and get back to work tomorrow. It's a week. Thank you, everybody, my co-conveners for this thing, Dr. Amit Ghosh, who suggested the topic. Thank you, everybody. Thanks. Good night.
Bye-bye.
All good night to all of you. Bye. Bye-bye.